Yeah, I think we can start.
Okay, sir. Good evening, everyone. It's very welcome to all
Swapna, your voice is not well audible, ma.
Sir, is my audible or a problem, Swapna, sir?
I think it's Swapna's only because
I was worried whether my signal is gone, so I thought.
Swapna,
Shubhashri, you are not at all audible, Shubhashri.
IIO Expert Insight on Lung Cancer. I'm Subhashi and I'm your host today. I sincerely thank each one of you for taking the time to joining us. Today's session has been thoughtfully designed to provide practical insight into the So am I audible?
you are not audible, ma, Subhashri. I think there is some problem with your net, I believe.
Sorry, sir. Give me 2 minutes of time.
Yeah, okay.
So am I audible?
Yeah, you are audible, ma. Yeah.
So good evening, everyone. A very warm welcome to all our esteemed faculty members and participants joining us today for IIO Expert Insight on Lung Cancer. On behalf of the International Association for Integrated Oncology, I sincerely thank each one of you for taking the time for joining us. Today's session has been thoughtfully designed to provide practical insight into the rapidly evolving landscape of molecular oncology in NSCLC. Before we begin, it's now my privilege to introduce our esteemed program director, Dr. Suresh Babu, Director and Senior Consultant, Medical and Hemato-Oncology, Krishna Institute of Medical Sciences, KIMS, Bangalore. Dr. Suresh Babu is a distinguished leader in thoracic oncology and has played a significant role in advancing precision oncology practice in India. Dr. Suresh Babu, thank you for being with us today. I now request you to kindly deliver the welcome address and introduce today's scientific meeting. So over to you.
Thank you, Shubha. I think the program when we planned, I think a lot of thoughts we put into it because we know as of today, I think the lung cancer is the one of the leading cancer in the world today. What it has made more complicated is the development of in molecular oncology. Previously, we used to have only EGFR. Sometimes even during my PG days, we never used to do molecular testing for a female non-smoker. We used to start Gefitinib or Lorlatinib without even doing molecular test. Now, that molecular testing has been so much that the things have become more complicated. Another thing which has complicated is the availability of the drugs. So, for example, last few months ago, I had a patient who has got both EGFR, ALK, and PDL1, P53, everything positive. Even in EGFR, there were two mutations which were positive. So, when you have more complicated case, then things need to be discussed and decided where to treat and how to treat. That's where the knowledge of molecular oncology is very, very important. So, even if you find a mutation like ALK or EGFR, now there are a lot of drugs. Then the question becomes which are the drugs which are going to be chosen, how to sequence them. These are the some of the things which come into picture when you have a case ahead of you. I think I must thank and congratulate IAO for taking up this topic. I think I had put lot of efforts to choose the topics per se. I think IAO also have taken lot of efforts to choose the speakers and other things. I think this CME is going to be of more useful to everybody, including me. I think with that introduction, without much delay, I will hand over to the IAO for the further proceedings of the CME. Thank you.
Thank you, sir. Thank you very much for your inspiring welcome and for beautifully setting the context for today's discussion. We shall now begin our scientific session. Our first speaker, it's my pleasure to invite Dr. Venkatesh Chaudhary, Assistant Professor and Medical Oncologist, Homi Bhabha Cancer Hospital and Research Center, Visakhapatnam. Dr. Chaudhary, the virtual podium is yours.
Yeah, hi. So can you allow me to share the screen, please?
Yes, sir. Please.
Yeah, now I got it. Yes. So it's all right? Audible and visible, right?
Yes, sir.
Yeah, okay.
Yeah.
Yeah, good evening. Delivering a talks and all these such important topics. And as already Dr. Suresh has highlighted, earlier era, it used to be like a very limited scope of getting a targeted testing done. And during our residency, even for metastatic setting, we used to be very difficult, challenging in getting a molecular test is out of question. At least we maximum try to get EGFR, ALK and ROS. These are the three things we could possibly do. And at least for the metastatic setting, we could get some second generation or first generation TKS and all. But now the precision medicine has evolved, and we are moving right from metastatic setting to the early stage lung cancers. So with this, our topic for the day is role of molecular testing and adjuvant targeted therapies in early stages of lung cancers. What do we have data, and what is our take on molecular testing? So this is the outline of my presentation. So at the end of the lecture, so what is the recommended biomarker testing needed for early stages, and also integrate the latest molecular and biomarker testing guidance in identification of oncogenic drivers in patients with early stages, and role of individual patient and tumor characteristics for use of adjuvant TKS in resected NSCLC or chemoradiated water. The data will be discussing few 3 to 4 trials, including the 2026 last 1 month back discussed trial in one of the marker. So these are the 3-4 trials which I will be discussing. So what is the role of biomarker testing recommendations in non-small cell lung cancer? So we know lung cancer has evolved. It's not like one disease entity, but many, like histology wise, non-small cell versus small cell, then followed by a histology breakdown in non-small cell, squamous, non-squamous like large cell, adenocarcinoma and all. Then coming to molecular pathology has been evolved. Earlier, which used to be like EGFR, ALK, ROS. Now there are multiple BRAF, MET, RET, N number. RAS and all. Then PDL1 expression, less than 1, more than 1 to 49, more than 50, multiple trials based on multiple levels of PDL1. So this is the present era, how it is running, right from histology, then type of histology, then molecular pathology, what are the various molecular types being positive, and immunotherapy based on the IHC, PDL1 levels. This is the evaluation of therapy. And in advanced setting, 50% of patients with advanced non-squamous have an actionable driver mutation, predominantly being KRAS, EGFR followed, and ALK. and other things like exon 20, MET, HER2, ROS, BRAF, RET, NTRK. These are the other things which we are seeing in advanced setting. But should we get test biomarkers at diagnosis or from the surgical resection? Earlier the better, because there are multiple neoadjuvant clinical trials. So earlier we have moved from metastatic to adjuvant. Now neoadjuvant also there are multiple trials coming. Neoadjuvant TKS, neoadjuvant immunotherapy, chemotherapy, multiple trials. So earlier the better. And all metastatic adenocarcinoma should have biomarker testing. Why earlier in neoadjuvant setting? Because we know if PD-L1 is positive, if you are giving immunotherapy, you should usually prefer to avoid EGFR, all targeted mutation positive patients. So earlier the better. But one more at the cost is, what is the biopsy tissue journey? How difficult or how feasible is it easy to get a biopsy? So it is not a it is challenging at times when the tissue is tumor is very small, or these are the challenges we could face, like tissue biopsy, which is by resection, excision of small tissue core biopsies, which is a block, paraffin block will be done, and then histology cytology will be seen. Then next, a fine needle aspiration or liquid biopsies. Of course, liquid biopsies in early stages not recommended, early lung cancers. But finally, these all things, histology, cytology will be done, and parallelly diagnostics. If tissue is limited, at least we'll restrict to IHCs like PCR, EGFR, or all cross. These are the limited IHCs, or a NGS lung panel, which many of our centers are doing. Limited NGS panel like 9-gene panel, 14-gene panel with PD-L1, without PD-L1. These are the things I hope at least 90% of us are practicing. Some go for advanced molecular testing also. So DNA, RNA, proteomics will be assessed based on PCR or MSA, NGS, comprehensive genomic panels, PCR, etc. So this is the various from tissue assessment, from biopsies processing, then morphological assessment and extraction and analysis, what all we could do. But again, as I said, liquid biopsy, not much role in early cancers as of now. But there are some studies, liquid biopsy, ctDNA role, escalation, de-escalation, these are things, but it's a part of trials right now, not yet in the guidelines. But what are the barriers? No initial biopsy, not enough tissue to do a molecular testing, and turnaround time is not fast enough, like waiting for 2 weeks. At least nowadays, at least they're taking 10 days to 2 weeks for getting a report initially to get a biopsy, then check for the molecular test, how much molecular sample is there for molecular testing, then going for a NGS testing or limited gene testing, then it will take at least a week or 10 days. But easier thing is, at least we can get in 48 hours, at least EGFR, ALK. So these are the things we should think of. And we should have a proper communication with a pathologist and simultaneously molecular pathologist who is doing an NGS. Finally, most concern is cost. Of course, now with many platforms have come in India with so many NGOs where they are getting for free, at least I can say. But still, who is going to pay? Sometimes the credit is an issue. They might not pay for outside people when in-house is not there. So multiple factors come into picture. So communication, tissue accuracy, turnaround time, and payment. These are the concerns in testing. Does it need PD-L1 testing make a difference in early stage? Yes, in metastatic, there is a predictive response for the single agent immunotherapy. PD-L1 is more than 50 and all. But currently, immunotherapy drugs are approved in both adjuvant and neoadjuvant setting, regardless of PD-L1 expression. But outcomes with immunotherapy are generally more favorable with high PD-L1 expression, or at least some level of PD-L1 expression. So finally, what biomarker test should we consider? At the minimum, EGFR and ALK, maybe soon RET might be into the picture. Still not at FDA approved, but the data has come recently, and all have implications for exclusion from neoadjuvant immunotherapy. So this is important, and both ALK and EGFR have adjuvant FDA approved therapies. PD-L1 testing, yes, benefit is seen regardless, but assist with treatment decisions. And what about entire gene panel? Earlier the better. Yes, this is also required if able to procure with a good amount of tissue and no finance issues, which gives more information about patient's disease status. So initial diagnosis, we have neoadjuvant EGFR ALK testing is done in PD-L1 IHC, because we have some neoadjuvant TK EGFR data also, and adjuvant EGFR ALK, RET, and PD-L1 IHC. Unresectable setting like chemoradiation who underwent, then EGFR testing. Broad NGS at advanced setting is needed at any time. All cases needed PD-L1 expression required if possible, and broad NGS panel or broad spectrum where at least 9-gene panel is needed if possible. And for squamous NSCLC, consider testing in young, never light smokers or female patients if biopsy specimen is of mixed histology also, NGS can be done. And what does this biomarker testing affect in early stages? Affects treatment decisions for neoadjuvant and adjuvant therapy, and timing of neoadjuvant therapy is an issue. Do not wait for weeks to treat. And how does PD-L1 fit in? Easy test offers some prediction for responses, but yes, we are not, irrespective of PD-L1, there is data to proceed. So with this background recommendations of biomarker, we finally have got to know, decided that S PDL1 is needed. NGS or molecular testing in early stages. S it is needed with the adequate amount of data we have. So now, what are the targeted therapies we could give in early stages of lung cancer? So I'll be discussing 3 to 4 trials in brief. So many of you would be knowing, but I'll just give a gist of this in brief. So as I said, from 4th stage, we have come to the earlier stages, targeted therapies and immunotherapies also. Earlier, relapse-free survivals or recurrence-free survival rates after surgery by stage. If you see here, first orange one is 3-year and 5th year recurrence-free survival rates. If you see stage 1, about 85 to 90% doesn't recur by 86% doesn't recur by 5-year survival rate. Stage 1B 62%, and overall stage 1 is 81%. But as the stage increases, the recurrence-free survivals they all reduce. So stage 2 50% only, and stage 3 5 years survival is 34%. So recurrence rates for stage 3 at 5 years are 66% if you see. So that is very much to be bothered. As the stage increases, the recurrence rates increases. And what is the impact of adjuvant therapy? This is where the adjuvant therapy, where we have Anita, LACE analysis, meta-analysis have come, which have proven benefit in later stages. Like if you see here stage 3 for most of all the trials, that is the lavender color or purple color, if you see, the numbers have increased. So as the stage increases, if you see stage 1 to 2 to 3, as the stage increases, the role of adjuvant therapy, chemotherapy mainly, that is increasing. And we all know there is a 5% benefit in absolute benefit, additional benefit by giving adjuvant chemotherapy for all those who is required. So finally, we have come to know that not just surgery alone doesn't do well. At the 5 years, there is less like 34% only as survival. So 66 are recurring. Then we have come to know that adjuvant chemotherapy plays an advantage. So what next? 5 years survival, same the whatever I have told earlier. Stage 1 80%, but stage 4 is 10 to 15%. And 50% of patients with advanced NSCLC, we know these all are the targeted possible agents, EGFR, ALK, we have multiple amount of drugs, KRAS, these are all the metastatic setting, which I can say. So these are all, we have known all these things. For the completion purpose, I have put this slide. And biomarkers, similarly in squamous also, we could see more adenocarcinoma, we see more of like KRAS and all, but in squamous, we could see FGFR, PTEN, and EGFR. We do see some amount of EGFR positivities also in young non-smokers. So they deserve to be done even in squamous cell carcinomas, young non-smokers, women. These are the people where we can try EGFR testing. Yes. So the slide of the day. EGFR adjuvant, we have ADAURA trial. ALK positive adjuvant, we have ALINA trial for alectinib. When RET, this is the 2026 May data, which is present in ASCO, Libretto 432, adjuvant selpercatinib versus placebo. And chemo-IO is permitted in this. So that I will be discussing later. And these are the ongoing trials for ROS1, taletrectinib, or KRAS G12C, olomorasib, or divarasib, and EGFR deletion exon 19, their new ADAURA trial, osimertinib alone. So these are the trials where adjuvant TKS have shown in a resectable cases. So target therapy is approved, osimertinib for exon 19 deletion or 21, up to 3 years or till progression, what sometimes some people do. And prior platinum-based adjuvant chemotherapy allowed in ADAURA trial. And alectinib approved as an adjuvant in patients following tumor resection for ALK positive tumors more than 4 cm or node positive up to 2 years, and no prior adjuvant chemotherapy in ALINA. And no other target therapies for now till date are approved apart from these two in neoadjuvant or even in adjuvant settings also. Coming to ADAURA, in brief, it is a phase 3 trial, completely resected stage 1B to 3A with EGFR 19 or 21 with performance status score who received chemotherapy also, and osimertinib versus placebo until 3 years or recurrence or discontinuation criteria, either because of toxicities or not. And primary endpoint beating DFS, and secondary endpoints are DFS in overall population, DFS at 2, 3, 4 years, OS, and other things. And exploratory endpoints are CNS DFS, and patterns of recurrence are being evaluated. And baseline characteristics, median age about 62, never smokers are more, if you see about 70 to 75%, Asian predominant about 65%, and adenocarcinoma being about 95 to 96% of the patient. And if you see here, 60% of the patients received prior chemotherapy, adjuvant chemotherapy. And DFS, the primary endpoint, if you see here, at the end of 2 years, it is 90 versus 55%, and 3 years is 85% versus 44, and 4 years is 73 versus 38%. And if you see 5 years also, more or less, it is doing, and hazard ratio of 0.27. That is one important thing we have has to be noted here. And median DFS being 65.8 months versus 28 months in placebo comparatively. So this is for overall population. But coming to OS also, in overall population, if you see, median OS is about 88% versus 78%. So if stage 1B to 3A, but if you see here overall survival by stage, if you see here 5-year overall share for 1B is 94 versus 88 with the hazard ratios 0.44, but it has slightly crossed the 1.02 hazard ratio intervals. And in stage 2 also 0.63, but if you see a stage 3A, osimertinib 85% versus placebo 67% with a hazard ratio of 0.37 and intervals being 0.2 to 0.64. And subgroup analysis, if you see, almost irrespective of chemotherapy, EGFR, stage 3A did comparatively well, but 1B and 2 slightly crossed. Smoking history, respectively, everything did favored osimertinib better. Safety summaries, all completed or discontinued study at final analysis. The safety was consistent with the primary analysis, no major issues and no other alarming side effects which could lead to like major discontinuations and all. If you see here, I would lead to discontinuation because of this. About 10% of the patients in osimertinib group compared to placebo is only 1%. And grade 3 leading to death is like 1%, one patient in both the group, and placebo 2 patients, but in osimertinib group only 1 patient. And serious events leading to discontinuation are about 13% in osimertinib compared to 3%. So not much harmful compared to the benefit it is able to deliver.
Sir, sorry to interrupt, sir. So 2 minutes left for the session.
Oh, sorry. Yeah, fine. So ADORA finally concluded that it is statistically significant. And similarly, okay, then I'll skip the LAURA. LAURA is anyway fine. So ELENA is one more trial in a phase 3 trial, adjuvant alectinib, which has shown role of potential oral TKI, and study design alectinib versus platinum-based chemotherapy. For 2 years, it was given stage 1B to 3A. And baseline characteristics are well balanced with no major toxicity. Non-squamous are about 95 to 98%. And efficacy, if you see here, DFS benefit, median DFS for 2 to 3A stage is not reachable versus 44.4 with a statistically significant p-value. And DFS benefit with alectinib versus chemotherapy observed across all the subgroups. And CNS, DFS and OS benefit is also there at the time of cutoff. OS was immature, but it is showing a favorable profile. Subsequently, patients have received in the crossover, they have received TKS in the subsequent therapy. Safety-wise, well tolerated without any major side effects. So it is first only positive phase 3 trial. DFS CNS benefit is there and adjuvant was tolerable, and investigator concluded adjuvant alectinib represents important treatment strategy. So this is the trial. In the last 1 minute I will take. It is the recently 1 month back it was published, presented in ASCO for selpercatinib in early stage RET positive. So if you see here, this has a hazard ratio of 0.17 with a 2-year event-free survival of 92% and no deaths. So this is the same study where after 1B, 2 or 3A resected, we are given selpercatinib versus placebo, and EFS is the primary endpoint. Where median age of 60 years and predominantly female, globally representative, never smokers are about 70%. And if you see here, EFS is about hazard ratio of 0.17, where 91.5% selpercatinib versus 61% at 2 years. And this benefit is seen across all the age groups. Investigate a hazard ratio of 0.17, and overall population is also 1.165. And EFS benefit remains consistent across age, sex, geography, ECOG status, and smoking history. Systemic intracranial progression is also distant occurrences very limited. If you see only 1 versus 18. So it drastically reduces local region failure and exhibit potential CNS system production. And overall, no deaths reported in the selpercatinib group also, and well tolerated. And treatment side effects are managed effectively through dose modification without forcing patients off potentially life-saving therapy. So can be managed. And common adverse events being hepatic derangement, diarrhea, and dry mouth and hypertension as the major concerns for this. So finally, early stage comprehensive biomarker is needed. RET fusion confirmation, or even we have adjuvant selpercatinib, or when we have seen other studies also like ELENA or ADORA, where EGFR and ALK also have proven established role as an adjuvant therapies. So with this background, I thank again IIO team and Suresh sir for providing this opportunity. Thank you.
Thank you, sir. Thank you for that excellent presentation highlighting the growing importance of molecular testing and targeted therapies in early stage NSCLC. So we now move to the next segment. I invite Dr. Joe Jose, Assistant Professor, Medical Oncology, Regional Cancer Center, Thiruvananthapuram. Along with him, our expert speaker is Dr. Praveen Kumar, Assistant Professor, Medical Oncology, Christian Medical College and Hospital, Vellore, Tamil Nadu. And invite Dr. Ruhi Kumar, Consultant Medical Oncologist, Sashwat Hospital, Rajkot. Over to you.
Yeah, I'll share my slides, right?
Yes.
Okay. I've sent a request.
Visible, sir.
Yes. So I'm going to talk about EGFR mutations in advanced non-small cell lung cancer regarding frontline strategies, optimizing sequencing, and overcoming acquired resistance. So EGFR driver mutations, if you look at them, they are, they're located within the tyrosine kinase intracellular domain between exons 18 to 21, right? And the most common ones are exon 19 deletion and exon 21 L858R. That's something that we all know. And the third most common is exon 20 insertion. We know that 19 deletion and 21 L858R are sensitive to anti-EGFR TKIs, whereas exon 20 insertion mutations are not sensitive to anti-EGFR TKIs. So getting straight away into the frontline therapy, in 2026, how do we treat a EGFR mutated metastatic non-small cell lung cancer patient? So we have, if you look at the evolution, it started off with first and second generation anti-EGFR TKIs in the form of gefitinib, erlotinib, afatinib, and dacomitinib. We slowly switched over to third generation TKIs in the form of osimertinib. And then we looked at combination therapies, combining first generation TKI with chemotherapy or with anti-VEGF-R agents. And you can see the survival here. Although it has slightly improved, from first and second generation to third generation, and with combination therapy, but still there was something that was missing. We could do better. So what was identified was that there were certain risk factors especially where the patients perform poorly. So age, the presence of baseline brain metastasis, the presence of TP53 co-mutation, and if you look at EGFR L858R, when compared to exon 19, it had poorer outcomes, and also liver metastasis. So, there was a need to improve outcomes in all patients, especially in patients with these features, right? And that's where we came to combination therapies involving third generation anti-EGFR TKIs. So we have two combinations. We have osimertinib plus chemotherapy and lazertinib plus amivantamab. So osimertinib plus chemotherapy is approved in the FLAURA2 trial. The FLAURA2 trial looked at patients with exon 19 and L858R mutations, right, with advanced disease in the first line setting. So it compared the standard of care at that time, which is single agent osimertinib, to osimertinib plus chemotherapy for 4 cycles, followed by maintenance with osimertinib plus pemetrexed. Okay. So what did this trial show? It showed a significant improvement in median PFS of 25.5 months versus 16.7 months with osimertinib plus chemotherapy. And this improvement in PFS was seen regardless of the EGFR subtype and regardless of the the baseline CNS mets. So when you look at the latest survival analysis, you can see that there's a significant OS benefit. The median OS was around 47.5 months, which is significantly higher than with osimertinib monotherapy of 37.6 months. And just like that, the survival outcomes were significant across patient subgroups, regardless of EGFR mutation type, and especially with CNS mets at baseline, which is a very poor prognostic factor. But with this combination, the survival outcomes were maintained even if you had baseline brain mets. So coming to safety, of course, there's a concern when you're adding chemotherapy and a targeted agent. There's a concern for increased toxicity. But the toxicity mostly manifested in the form of myelosuppression. So you had anemia, you had neutropenia, but this did not lead to an increase in severe toxicities or life-threatening toxicities. And there was a high discontinuation of maintenance pemetrexed. So around 50% of the patients discontinued pemetrexed, but there was no major increase in discontinuation of osimertinib. So you can see here that most of the patients discontinued. Of course, you had 4 cycles of platinum. Then pemetrexed maintenance was discontinued at an average time of 8 months. And osimertinib was continued for most patients. There was no major increase in discontinuation of osimertinib. And despite discontinuing pemetrexed early on, there was significant improvement in survival. So coming to the toxicity, you can see that it is mostly front-loaded when you're giving the doublet chemotherapy, and when you switch over to maintenance pemetrexed and osimertinib, the toxicity profile it decreases, the incidence of toxicity that is. So coming to the second combination, we have amivantamab plus lazertinib. This is based on the Mariposa trial. So amivantamab is a bispecific monoclonal antibody. It targets two receptors, extracellular domains, that is the EGFR as well as the MET receptor. So MET receptor probably is being targeted because MET is one of the most common resistance pathways when you treat with an anti-EGFR TKI. So this was compared in the Mariposa trial. So you had amivantamab plus lazertinib that was compared to osimertinib. And once again, this showed a significant improvement in the progression-free survival, which was, which carried over into the overall survival with a significant OS benefit. In fact, the median OS, as of the latest update, is not reached in the amivantamab plus lazertinib arm. And once again, just as we saw with the chemotherapy plus osimertinib combination, the effect of this was seen across subgroups, regardless of the patient subgroup. So coming to the adverse effects, of course, we know that amivantamab has a unique toxicity profile. So you have, skin and nail toxicity, you have hypersensitivity reactions. Then with this combination, you also have, thromboembolism as well. So if you look at this, actually, most of the toxicities are very front-loaded. So in the first 4 months is where you see most of the toxicities. And as time goes on, especially beyond 12 months, the toxicities, the incidence comes down drastically. So to further decrease the toxicity profile, we had various other trials that looked at various prophylactic regimens that could decrease the toxicity. So for infusion reactions, they considered giving pre-medications with oral dexamethasone. And for venous thromboembolism, they gave oral anticoagulants in the SKIP, that was in the Paloma 2 and 3. And for dermatological prophylaxis, they gave, in the Cocoon trial, they gave antibiotic prophylaxis with doxycycline from week 1 to 12. And from week 13 onwards, they gave topical antibiotics. And they also gave nail cleansing and skin hydration agents as well. So with the addition of all these prophylactic measures, you can see that the dermatological toxicity has significantly come down. The infusion reactions as well as the thromboembolism rates have also significantly come down with the addition of these prophylactic regimens. One other point to be noted here is that this trial was done with intravenous amivantamab. So currently the FDA has approved subcutaneous amivantamab, which will probably make its way over here soon enough. So with that, there's a significant decrease in infusion reactions as it is, without the prophylaxis even. So to summarize these two combination regimens, you can see, like I mentioned that all these high-risk features, with the first and second generation TKIs and third generation TKIs and the first generation combination therapies, the outcomes are poor, especially in these high-risk groups. But what we saw in Mariposa and Flora 2 is that regardless of the EGFR mutation, regardless of the presence of brain mets, regardless of the presence of liver mets or TP53 co-mutation, which are all high-risk features, there was an improvement in the overall survival. So coming to the efficacy in CNS mets, the combination therapy actually has excellent CNS overall response rate as well as CNS PFS. Okay, so because of the excellent blood-brain barrier penetration with these combination therapies and the good control in the intracranial cavity, because of that, you can omit WBRT and SRS in patients with upfront brain metastasis. In fact, if you look at the trial data in Flora 2, only 7% of the patients underwent WBRT and 7% underwent SRS. These are the patients with upfront brain metastasis. So basically, because of the excellent blood-brain barrier penetration of these third-generation TKIs, and especially in the combination format, you can avoid WBRT because the majority of the patients who receive WBRT develop neurocognitive decline, and we know that these patients are living longer than ever before. So we are living for average of 4 to 5 years. So it is of paramount importance to decrease that post WBRT complications in the form of neurocognitive decline. And even despite the fact that we have these third generation combination therapies, there's still some role for first line osimertinib alone. That is in patients with poor performance status, right? So they might not be fit for combination therapy, or if you have an EGFR exon 19 deletion with no adverse risk features, you can consider talking about osimertinib alone. And of course, patient preference plays. Yes.
So 2 minutes left for the session. Sorry to interrupt.
Yeah, that'll be enough. Yeah. So another important point here is patient preference. So if the patient does not want to undergo the side effects of chemotherapy or adding amivantamab, there also you can consider osimertinib alone. So it's a decision that has to be made with incorporating the patient's opinion as well. So coming to tackling acquired mutations. So when if the patient progresses, there you need to do a repeat biopsy because you need to look and identify the resistance mechanism at play. So unlike the upfront presentation, you should ideally do a tissue biopsy from the progression site, and if possible, combine it with a liquid biopsy because that will account for the tumor heterogeneity, which is present in a higher amount when the disease progresses. So what sort of mutations are seen when the patient progresses on a TKI? So you have on-target mutations. So you have EGFR mutations, most commonly C797S. Then you can also have histological off-target mutations like histological transformation. You can have another membrane TKI that's activated. You can have downstream pathway that's been activated. So all those are the on-target and off-target mutations that can develop. So the pattern varies depending on what you've given in the first-line setting. So if you've given a first or second-generation TKI, most common mutation is T7 and TM. If you've given a third-generation TKI, the most common mutations seen are MET amplification and C797 mutations of the EGFR receptor. So like I said, 50 to 60% of the patients who progress on third-generation TKI will have an identifiable resistance mechanism. So based on that, you can treat with two approaches, either a targeted approach or a non-targeted approach, right? So coming to the targeted approach, so suppose you identify a specific resistance mechanism, for example, trans C797S mutation. In this case, you can actually re-challenge with a first or second-generation anti-EGFR TKI. It happens to work well in that setting. So if it's a cis-position C797S mutation, another option is cetuximab plus brigatinib. Now, MET amplifications are most commonly seen, especially after third-generation TKIs. So in that setting, you can use a combination of continue using osimertinib plus a MET inhibitor, or you can, based on the MARIPOSA-2 trial, you can give chemotherapy plus amivantamab. And of course, if it's the histological transformation, you treat according to that. Now, coming to the non-resistance targeted approaches, suppose you have not identified a resistance mechanism, or if the resistance mechanism is not targetable, or if a repeat biopsy is not possible, you can go for these methods. So you can combine chemotherapy plus an anti-VEGFR agent, right? You can combine chemotherapy plus anti-VEGF plus anti-PD-L1, that is the ABCP regimen. We have some data for that based on the IMpower 150 subgroup as well as the Atlas trial. Then you can give chemotherapy plus amivantamab, once again based on the MARIPOSA-2 trial. And there's also anti-HER3 targeting ADCs such as patritumab deruxtecan, right, based on the HERTHENA trial. Although this particular agent was withdrawn by the company later on because there was no significant OS benefit. Then you have some TROP2 targeting ADCs such as datopotamab deruxtecan, and also recently, this is under FDA review, sacituzumab tirumotecan as well. So these are this is how you treat a patient who's progressed on a third-generation TKI-based regimen. You can have targeted as well as non-targeted approaches. So in conclusion, the current standard of care and frontline management of EGFR mutated metastatic non-small cell lung cancer is either osimertinib plus chemotherapy or lasitinib plus amivantamab. Both combinations show improvement in outcomes, and choice of treatment should take toxicity profile and patient preference into account. On progression, of fresh tissue biopsy, ideally along with the liquid biopsy, is preferable, right? And treatment on progression can, depending on the resistance mechanism identified, can take on targeted or a non-targeted approach. Thank you very much.
Thank you, Joseph. So our next speaker, Praveen sir. Over to you, sir.
Thank you for the invitation. I'm happy to be here in this platform to share my thoughts on ALK positive non-small cell lung cancer. I'll be covering current standard of care, next generation TKIs, as well as CNS management. In India, the ALK rearrangement incidence is somewhere between 3 to 11.4%, and majority of those are the classical EML4 ALK fusion, and other ALK fusion variants are seen as well. Classically, the clinical profile is one of a young non-smoker or a former light smoker, but this typical clinical profile need not always be the case. And you can call someone who's having a diagnosis of lung cancer at less than 40 years of age to be having a young lung cancer. the incidence is somewhere around 10%. This is important because we see a more number of fusions present in this population, namely ALK fusion ret or ROS fusion, ALK being the most prevalent of those fusion in these patients with young lung cancer, with an incidence of as high as 34%. We know that ALK positive lung cancer has a high propensity for brain metastasis. And if we talk about the first in class ALK TKI to be approved, crizotinib was proven to be superior in terms of efficacy when compared with standard chemotherapy with the trial done in the last decade, and it saw the approval of crizotinib as first line management in patients with ALK positive non-small cell lung cancer. And all the trials that came after this always compared crizotinib in the control arm, and whichever newer ALK TKI was evaluated, they had enrolled patients with locally advanced or unresectable patients with non-small cell lung cancer, or those patients with advanced non-small cell lung cancer with ALK positive disease. And more frequently, these patients have had brain metastasis at baseline, and there has always been a subgroup of patients who had the brain metastasis versus who do not, to be able to inform about the intracranial efficacy of each particular TKI. One such trial is ALEX trial, in which alectinib was compared against crizotinib, and alectinib was proven to be superior to crizotinib in terms of median progression-free survival as well as overall survival. The absolute overall survival benefit at 5 to 7 year time frame was around 10%, and this is the updated overall survival results as per the results published last year. So we see that alectinib has a much better intracranial penetration when compared to crizotinib, and we see the superior efficacy of the same in terms of overall survival for patients with brain metastasis at baseline for alectinib. And if we take a look at the systematic review and meta-analysis done for second-gen ALK TKIs, they have always proven to be superior when compared to their first-generation counterparts as well as chemotherapy. So whenever we talk about newer generation of ALK tyrosine kinase inhibitors, what we mean by that is every new generation has a better on-target potency, has a better mutational coverage, and has a better CNS penetration effect, and thereby getting evaluated in clinical trials and getting their FDA and EMA approval designations. So this is the depth of mutation coverage for each ALK TKI across generations. We see that lorlatinib, the third generation ALK TKI, shows the best depth of mutational coverage for all ALK TKIs. And I would like to draw your attention to some of the resistant mutation, like some of the most common resistant mutations like G1202R and L0096M. We see that the earlier generation ALK TKIs were not proven to be efficacious in these mutational patterns, whereas you can see the efficacy of lorlatinib across these mutation patterns. I do want to highlight that while lorlatinib is efficacious against each individual mutations, it is not effective when a compound mutation is present. And that is where an unmet need exists in present-day ALK positive lung cancer, wherein there is a need for a better ALK TKI than lorlatinib, especially for patients with compound mutation ALK resistance mechanisms. So we saw the update of the CROWN trial in ASCO 2026, wherein the principal investigator, Dr. Tony Mock, presented the 7-year updated PFS for lorlatinib when compared to crizotinib, and showed that the 7-year PFS was 55%. It is the highest PFS known for any targeted therapy in lung cancer to date. So we saw the impressive intracranial progression free interval for patients who are getting lorlatinib in the arm. In fact, Dr. Mock made a comment that if a patient is able to cross 2 years without progressing in the brain, this is for patients who have baseline brain metastasis. If they are able to cross that 2-year time frame, there is over a 90% chance that they will remain progression-free in the brain even at a 7-year time frame. So we can see the impressive results for patients with baseline brain metastasis. They are continuing to live disease-free several years after the start of their first-line therapy with lorlatinib. It does have a unique adverse event profile, lorlatinib, when compared to its earlier generation TKIs, ALK TKIs. There are metabolic adverse events like hypercholesterolemia, hypertriglyceridemia, resulting in weight gain and fatigue. And another important pattern of side effects are the neurocognitive side effects. Ataxia and cognitive defects are seen with patients who are getting long-term ALK TKIs, that is long-term lorlatinib, and that is where some patients do have a dose-limiting toxicity. So this slide is just a readout of each individual trials. I'm not obviously I'm not trying to do a cross-trial comparison. This is basically a readout of overall survival data that each trial has shown. We have seen overall survival of 76%, a 5-year overall survival of 76% for the earlier phase lorlatinib trials. The ground data is not yet published. The OS data is still awaited. Whereas ALEX showed a 5-year overall survival of 62% and brigatinib showed a 4-year overall survival of 66%. And it all comes down to the fact whether patient has baseline brain metastasis to begin with, whether it is symptomatic brain metastasis or not, what is the volume of brain metastasis is present, what is the how early do you need the response for that particular patient. And that is where this graph kind of gives us an idea as to each individual drug's intracranial response rate. We see that patients with measurable brain metastasis shown in orange, lorlatinib has the superior intracranial response rate, 78%, followed by alectinib 72%, and followed by brigatinib 67%. So this is present day NCCN guidelines, which says that four drugs, alectinib, brigatinib, ensatinib, which is another second-gen ALK TKI, and lorlatinib can all be options in the first line for ALK-positive lung cancer. And crizotinib and ceritinib are usually reserved for patients who do not, unfortunately, have access to these newer agents, or because they are asymptomatic and can be kept on these early generation TKIs until they progress. So important to notice that if a patient is started on chemotherapy while awaiting NGS, if and when the ALK fusion is found, it is advisable to stop the chemotherapy and switch to an ALK TKI. That is the present day recommendation. And this is mostly a personal opinion. You can take it if this is just purely my perspective on who I would prefer lorlatinib, especially in patients with multiple brain metastasis when you need a earlier intracranial response, for patients with rectomeningeal carcinomatosis, for those patients who have the classical EML4 ALK variant 3. For those patients, lorlatinib is definitely preferable. And alectinib is the most cardio-safe ALK TKI. So for patients who have cardiovascular comorbidities, or those patients with pre-existing cognitive impairment, for patients who are relatively asymptomatic, you can prefer alectinib. Another thing is for patients who have limited primary caregiver support, again, you can consider alectinib. And this is the low-dose lorlatinib trial that was presented at ASCO 2026 from TMH Mumbai, in which they had used lorlatinib 25 mg for patients who had received at least one line of previous ALK TKI, and they got a decent intracranial response rate of 25% and a disease control rate of 37%. This is, of course, for patients who have limited access to the drug. And we do have our own trial, which is running in CMC Vellore by one of my colleagues, Dr. Ruth. It is looking at, again, a lower dose lorlatinib in combination with itraconazole. And we are doing the pharmacokinetic sampling and analysis and measuring the objective response rate. This trial is currently ongoing and is funded by the IASLC. Future directions, there is one 4th generation ALK TKI called neladalkib, which is more ALK selective and TRK sparing. By that I mean patients are spared of the neurocognitive effects of lorlatinib while retaining the CNS penetrance effects of lorlatinib. So this is an impressive readout of the preliminary results at ESMO 2024, in which for patients who had received 2 or more generations of ALK TKI, including lorlatinib, it showed an impressive objective response rate of 47%. And for compound ALK mutations, the response rate for 54%, which is quite impressive, and we can look forward to the matured results of this drug. ASCO 2026 also saw some peptide ALK vaccines being used in concurrently with lorlatinib. The Archer trial did show some clinical benefit for patients, especially with resistant mutation like G1202. And another trial, which is a global phase 3 trial, which is ongoing, in which neladalkib is compared against alectinib. Thank God they are not comparing against crizotinib for another trial. And this is something that we can look forward to in the future. And we saw that alectinib is getting pushed to earlier lines and in the adjuvant setting, and there is a revolving role for lorlatinib in stage 3 lung cancer as well. So to conclude, what was once an incurable disease is now becoming a chronic manageable disease with responses lasting for longer and with a reasonable quality of life. The CROWN trial, as said, was shown to have the longest PFS for any targeted therapy in lung cancer to date. And while the science is advancing, we need to close the care gap as physicians and convey our health policy makers for our patients to be able to have better access to these newer agents. Thank you.
Thank you, Praveen sir. Next, Ruhi ma'am, over to you.
So very good evening, everyone. I'll just share my slides. Are my slides visible?
Not yet, ma'am. Yes, visible. Visible, ma'am.
Okay, sure. Thank you so much. So, good evening, everyone. I'll be talking about navigating the rare genomic alterations and their therapeutic, which are the emerging agents and the future directions that we are going in. And I'm a consultant medical oncologist in Shashwat Hospitals in Rajkot. So coming up to the rare genomic alterations, they are usually the receptor tyrosine kinase, and via the PIK3 pathway or the RAS-RAF pathway, they affect the cancer cell. Some of the mechanisms are not known that much in detail. This was a paper by Dr. Sharma et al. Published in JCO Global Oncology in 2025, which was the genomic comprehensive profiling of around 5,000 plus patients of NSCLC, and it was published with the TMH in collaboration with TMH. So we are going to be focusing on these rare genomic alterations: ROS, RET, MET, NTRK, BRAF, HER2, etc. So they are very, by rare, we mean they are present in less than 1%, less than 5% of the patients. So if a patient has NSCLC, the chance of having HER2, MET, BRAF and all is less than 5%. And we know this through our normal clinical practice. The normal flow of treatment is usually we do a broad NGS, we identify the driver mutation, and then we use the first line of targeted therapy. And one corollary here is that now we are moving towards using the best CNS directed TKI. Once there's progression, we repeat a tissue biopsy, do a liquid biopsy if feasible, and then we move on to the next generation TKI, ADCs, or a clinical trial. So coming to ROS1, incidence is 1 to 2%. The common fusion partners are here. Usually there are brain metastasis more common, and we know that if this common mutation is there, then there is resistance to first generation TKIs, and we should look towards the next generation TKIs. So crizotinib was established by this trial profile 1001 with the overall objective response rate of 72%, and entrectinib was established in the phase 2 Star Trek trial with the objective response rate of 77%, and in the upcoming drug is taletrectinib, which was established by the TRUST-1 trial with the objective response rate of 85% in a crizotinib naive patient. The emerging therapies are repotrectinib and taletrectinib, which is active in the resistant setting. Coming to RET, That's also incidence is 1 to 2%, and there are gene fusions or rearrangements with brain metastasis is very common. And libretto trials are the selpercatinib trials. This is very relevant to us because selpercatinib is now available in India. And pralasatinib trials is the ARROW trial with the objective response rate of 70%. In all the rare genomic trials that I'm going to be talking about, this Libretto 431 trial is the only phase 3 trial with published data of almost double the median PFS, with a very good hazard ratio of 0.24 and a objective response rate of 84% versus 36%, with the confirmed superior first-line therapy. Future drugs, we are looking at LOXO 260 and TPX 0046. Also, we need to see that these drugs have a very good CNS efficacy. So actually below here, I have mentioned few papers. These are the, if you open these papers, like we can go into detail of what the ROS1 characteristics of NSCLC are. And this is also a very good paper for RET mutation in NSCLC. Then we have the MET exon skipping mutation. We have to remember that MET amplification is not the same as MET exon skipping splice site mutation, which is oncogenic in action. The incidence of this is 3 to 4% in NSCLC. Brain mets are more common, and it's often seen in never smokers or light smokers. So the common exon 14 skipping mutations are here. The common drugs that we know about is capmatinib through the Geometry Mono 1 trial, tepotinib, the phase 2 Vision trial, and the amivantamab plus lazertinib, which is the Insight 2 trial for the EGFR mutant with the MET amplification after EGFR TKI failure. Objective response rate is around 50% with median PFS of around 8.3 months. So the emerging agents are ivonescimab, the telisotuzumab vedotin, and the bosutinib. This is again a very good paper in JTO Clinical Research by Dr. Ying Hang et al., where he has mentioned the antibodies, the TKIs in different MET mutations and the ADCs which are upcoming. So as you can see, there's MET exon skipping mutation, MET amplifications or overexpressions, and MET fusions. So future directions, not just for MET, for all the drugs is all the mutations is basically antibodies plus TKIs, TKIs plus TKIs, TKIs plus ADCs, and ADCs plus IO. Coming to BRAF mutations, so these are the different type of BRAF mutations, class 1, 2, and 3. Class 1 and 2 are RAS independent, and class 3 are the RAS dependent mutations. And usually the BRAF inhibitors that we are using right now are class 1 inhibitors. And next generation RAF inhibitors are coming up, which will target the class 2 and class 3 mutations as well. So when it comes to targetable mutations, we divide them in V600E mutations versus the non-V600E mutations. So they are also present in 1 to 2% of NSCLC, and this is the timeline of how these drugs were developed and approved. So dabrafenib, trametinib was approved in 2022, and now encorafenib and binimetinib has been approved in 2023. So dabrafenib, trametinib trials are the trials by Dr. Blanchard et al. The previous mutations I showed was also by a paper Dr. Blanchard et al. Had written. It's a very good paper for BRAF mutant NSCLC for reference. So we know that sequential inhibition with dabrafenib and trametinib is more effective than just the monotherapy. This was the paper which showed objective response rate of 68% with the median PFS of 10 months and intracranial objective response rate of 58%, which was very well tolerated. So current regimen based on the Pharos study has an objective response rate of 75% with median PFS of 15 months and intracranial ORR of 46 months with manageable safety profile. Emerging trends are the pan-RAF inhibitors and the inhibitors which are called paradox breakers. Basically, they avoid the paradoxical MAPK activation, which is seen when you give BRAF inhibitors alone. Coming to enteric fusion positive NSCLC, less than 1%. Usually, there is strong oncogene addiction, and we know larotrectinib, based on this Navigate and Scout trials, having an ORR of 75%, and entrectinib based on START-TRU trial of ORR of 77% with a superior CNS penetration. Repotrectinib and selitrectinib are the upcoming drugs in the next generation enteric tumor agnostic approvals. Coming to HER2 in NSCLC, so first we have to differentiate between the three distinct alterations, which are the mutations, the exon 20 insertions, the amplifications, and the overexpressions. So these are not the same thing. We have to be careful when we are diagnosing the patient or interpreting the NGS report. So again, these two papers are very good reviews of HER2 mutation in NSCLC. We know trastuzumab deruxtecan is coming up in a very big way across all drugs. So Destiny Lung 1 and Destiny Lung 2 trials showed the higher intracranial response, the good durable responses, the good median PFS, objective response rates, etc. And the emerging therapies are zongertinib, disitamab vedotin, trastuzumab rezetecan, and HER2 bispecific antibodies. Special shout out to this Destiny Lung 04, which is an ongoing phase 3 trial. So in all the rare genomic alterations which I have discussed, we have a Libretto 431 trial, which has a published phase 3 data. So this is the ongoing phase 3 trial in HER2 positive NSCLC setting, where TDXT is being used in the first line setting, where the primary endpoint is PFS, and there are other secondary endpoints that we are looking forward to as well. So it could be the next practice-changing trial. So emerging trends, we can see that there are drugs, the newer drugs have better CNS penetration with improved brain exposure and activity like repotrectinib and selpercatinib. We are overcoming resistance, the target resistant mutations with taletrectinib, which is and LOXO 260. There is an ADC revolution which is being led by Asia, especially China. We know that a lot of drugs are coming up with good phase 2 and phase 3 data. And we are moving into the earlier use as discussed previously in the neoadjuvant and adjuvant trials. And ctDNA guided sequences is also coming up in a very big way across all the tumors and especially in NSCLC, where we are doing real-time molecular profiling to guide dynamic treatment decisions. So future directions are the CNS active drugs, combination target therapy, like I showed TKI plus TKI, ADC plus TKI, ADC plus IO. There is an ADC revolution with earlier stage targeted therapy, ctDNA guided sequencing, and a resistance directed precision oncology. So my take home messages are comprehensive NGS is mandatory. CNS penetration is now influencing the first line TKI drug choice. We have to be wary of the resistance biology, which determines sequencing. And ADCs are rapidly expanding, not just in HER2 breast cancer, but across all tumors. And clinical trial enrollment remains essential. So thank you. And this was a very short presentation because drug specific and mutation specific work is ongoing, and we have to keep updating ourselves and see what drug can benefit our patients in clinical practice. So thank you so much for giving me this opportunity.
Thank you, ma'am. Thank you for such an informative presentation. So we now move to our next scientific lecture. It's my pleasure to invite Dr. Shrikant Ravichandran, Consultant Medical and Hemato-Oncologist, SCG NMR Cancer Center, Karnataka. Dr. Shrikant, sir, over to you.
Hi, good evening. Can I share my own slides if you don't mind?
Yes, sir, sure.
Is my screen visible to everybody?
No, sir, not yet.
How about now?
No, sir, it's very like small size.
Is this okay?
No, sir.
Then, how about now?
No, sir, it's not like it's very small size, not in big size.
All right, then I would like to request you to share the screen.
Okay, sir. Okay,
and
sir.
the slides. Yeah, so good evening all, and I thank the organizers of IAIO and Dr. Suresh sir and the Takeda team for giving me this platform to speak today. So my topic for today is precision practice regarding a specific drug that is brigatinib by the management of metastatic non-small cell lung cancer, which is ALK positive. Next slide, please. We've already seen from the previous speakers and they have elaborated in great detail, especially Dr. Praveen from CMC Vellore has already spoken regarding various trials in ALK positive NSCLC. So I'll keep this as short as possible. Can I have the next slide, please? Next slide, please.
Yes, sir.
Give me 2 minutes of time. Sorry.
Yeah, sure. Yeah, thank you. So we have already seen that predominantly these ALK positive mutations are seen in those who are non-smokers, young age, and they tend to have brain metastasis at presentation and have adenocarcinoma histology. Not to say that these are not seen in squamous cell histology. So squamous cell histology should also be tested for the same. Coming to a timeline of the approval, the EML ALK mutation was first detected at 2007. Can I have the previous slide, please? Yes. AML ALK was detected in 2007 in the first, the mutation was detected in 2007, following which crizotinib, the benchmark, was introduced in 2011, and the full approval was gotten on 2013. 2017 was an important year for the NIBs, with brigatinib, lorlatinib achieving some kind of approvals. And the latest approval which has been given is for ensatinib. Next slide, please. Yeah, next slide. So coming to the small short introduction, this brigatinib, as we all know, is a very specific TKI which is inhibiting this NPM ALK fusion protein and demonstrates a dose-dependent inhibition of the EML4 ALK positive NSCLC. It has demonstrated in vitro as well as in vivo activity against various mutant forms of ALK positive NSCLC, such as G1202R and L1196M, which has already been previously discussed. So this reduced tumor burden and prolonged survival in mice implanted intracranially with an ALK-driven tumor cell line is what was used. Can I have the next slide? Yeah, so in India, it is approved both in the first line, not previously treated with any ALK inhibitor, and also with those who have previously been treated with crizotinib, with an leading up dose of 90 milligram oral once daily dose of 7 days, following which the dose is increased to 180 milligram once daily dosage. It may be taken with or without food. Dosage forms and strengths available are 180 milligram, 90 and 30 milligram. Can I have the next slide? So they're coming to the NCCN recommendations for an advanced or metastatic and positive NSCLC. This has already been seen previously. If it is diagnosed prior to first-line therapy, then we have alectinib, brigatinib, azacitidine, and lorlatinib as first-line category 1 indications. And if it is discovered during the first-line systemic therapy, then it's better to stop the systemic therapy and go on with the above TKIs. The next slide, please. The ESMO guidelines also recommend the same, having the alectinib, brigatinib, lorlatinib as category 1A indications. And on subsequent line, if there is an oligoprogression as is with the EGFR mutations, we go ahead with the local treatment and continue the same systemic targeted therapy. And upon a frank systemic progression, we rebiopsy, see the cause for progression as already been previously described, see any new mutations or change in histology and treat accordingly. If there is no change in the mutation status, then we go ahead with alectinib, brigatinib, or any ceritinib or lorlatinib. And if again systemic progression occurs, then lorlatinib becomes our only choice unless any other new drug comes into the picture. Apart from that, we have other target non-specific backbones like pemetrexed platinum chemotherapy and ABCP. Next slide, please. So this has already been discussed previously. Brigatinib is active against ALK resistance mutations. The most commonly seen ALK resistance mutations are the L1196M and G1202R mutations, against which brigatinib is active. And lorlatinib and brigatinib are the only mutations, the only drugs which are active against these mutations. The compound mutations, that is the combination of 2 or more mutations, is what is the need of the hour, as has already been previously described. So some compound mutations, are it is resistant to even lorlatinib, such as the combination of G1202R and L1196M mutations. Agents like brigatinib retains activity in select lorlatinib resistant scenarios, such as the below described mutations, that is L1171N and L1198F and so on and so forth. Can I have the next slide, please? So I'll be describing the first-time treatment of brigatinib in 3 important trials. ALTA-1 that described the brigatinib in the first-line setting, the BrightStar trial that combined brigatinib with a local conservative therapy approach, and the Explore-ALK trial, which was a real-world study comparing brigatinib, lorlatinib, and alectinib. Next slide, please. So this was a phase 3 study for brigatinib. It included patients who were greater than or equal to 18 years with locally advanced or metastatic NSCLC who were ALK positive and ALK TKI naive. They could have received systemic therapy in the first-line setting. Randomized in a 1:1 ratio for brigatinib versus crizotinib. And the primary endpoint was progression-free survival, and secondary endpoints were overall survival, duration, response, health-related quality of life, response rates, intracranial as well as systemic, and so on and so forth. Can I have the next slide, please? So this was a population that was reflective of real-world patients. We all know that is ALK positive is seen in an elderly age, with median age of being 58 to 60 years in this trial, female population of around 50%, an Asian of around 43%, and CNS metastases were present in about 30%, adenocarcinoma, stage 4, and newer or former smokers all equal to or above 90%. Can I have the next slide, please? So brigatinib, it demonstrated a powerful systemic efficacy with almost a 3x median PFS versus crizotinib in the intention to treat population, with 30.8 months versus 9.2 months in the crizotinib arm, with a hazard ratio of around 0.43. Can I have the next slide, please? This also had a strong intracranial efficacy. Longer lasting intracranial responses were seen. So the median intracranial PFS in patients with brain metastasis was 24 months with brigatinib versus 5.5 months with crizotinib. And the complete response rates with brigatinib was around 45% versus just 2% with crizotinib. The hazard ratios were also impressive with around 0.29. And the response duration in the intracranial response was around 27.1 months with brigatinib and just 9.2 months with crizotinib. Next slide, please. So the ALTA first line also demonstrated a strong intracranial efficacy not only with patients who had a brain metastasis, but also without brain metastasis. So the combined population had almost a 4-year PFS of around 44.1 months, which is just 21.2 months with crizotinib with hazard ratio of 0.44. Next slide, please. So the brigatinib not only improved the PFS and the intracranial response rates and the intracranial progression-free survival, but it also resulted in a better quality of life and better global health status. That is patient-reported symptomatic as well as side effect profile. So the time to worsening was assessed by physical scales, emotional, cognitive, and social functioning scales, and improvement of disease symptoms, which showed that this median time to worsening with brigatinib was around 26.7 months versus just 8.3 months with crizotinib with a hazard ratio of 0.7. Next slide, please. So this is just a gross cross-trial comparison. I know we should not be doing this, but just to have a broad look at cross-sectional view across all the trials of brigatinib, alectinib, and lorlatinib. So one important thing was prior chemotherapy regimen was allowed in the ALTA-1 brigatinib study, and most importantly, the crossover was allowed with brigatinib, but it was not allowed with alectinib or lorlatinib trials, which can kind of explain why you have such a great PFS and OS curves with lorlatinib. And the PFS that was seen with brigatinib was BACR assessed, whereas in Alex trial it was investigator assessed. Can I have the next slide, please? So coming to the Bright Star trial, which showed brigatinib in combination with local conservative therapy. It was a phase 1 trial which included patients with documented ALK rearrangement and who were TKI naive with either oligometastatic or polymetastatic disease. So in this setting, the cutoff was 3. They gave brigatinib for these patients for around 2 months, and then they took them up for local conservative approach in the form of either surgery or radiation therapy. If less than 3 active sites, then definitely local conservative therapy was given. If greater than 3 sites were present, then it was given at physician discretion. And then the patients were continued on brigatinib until progressive disease or unacceptable toxicity. They were evaluated for PFS, OS, and time to progression. So the objective was to assess the safety and efficacy of brigatinib in combination with any local conservative approach in TKI naive advanced ALK positive NSCLs. Next slide, please. So these again took patients who had a median age of 55 years with a female population of around 59% with a histology predominantly adenocarcinoma with various AML4 ALK variants with less than 3 ALK metastasis with just 20%, with most being polymetastatic at around 82%. The partial response was around 80%, and stable disease was around 20%. Next slide, please. So what this showed was when a local conservative approach like radiation therapy, which was given in 80% of the cases, or surgery was given in around 59% of the cases, or a combination was given around 6% of the cases, it showed better control of the disease with tolerable side effects, with majority of the side effects being anemia, pneumonitis, esophagitis, vomiting, nausea, which could be managed. Pneumonitis, if it was seen, which was seen in 3% of the cases in this setting, was treated with corticosteroids, stopping of brigatinib and switching over to alectinib, upon which they continued without any evidence of progressive disease. There were no grade 5 events related to brigatinib plus local conservative therapy approach. Can I have the next slide, please? So this is what it hoped to prove, that when you combine for any oligometastatic or polymetastatic disease with brigatinib along with local conservative approach, the median PFS was around 66 months with 61% 3-year PFS. Comparing that to ALTA first line trial, which again included these metastatic patients, the 1-year PFS was 94 versus 80%, 2-year PFS was around 81 versus 56%, and 3-year PFS was around 60 versus 47%. So combining this local conservative approach along with brigatinib was safe, tolerable, and it also improved the PFS compared to the giving the brigatinib alone. Can I have the next slide, please? So coming to the real world evidence of Explore ALK study, which was a prospective non-interventional study of first-line ALK TKI monotherapy. It is ongoing and still recruiting patients. Prospective and non-interventional multi-center study, which included patients of around 70 patients of brigatinib, 150 patients of alectinib, and very few patients of lorlatinib, just 6 in number. So they were given first-line treatment of ALK-directed TKIs at physician's choice, and the primary endpoint was OS, and secondary endpoints were phenotyping of the study population, treatment sequences, efficacy and safety of the TKI, and disease progression modalities and current practices to identify resistance mechanisms. Can I have the next slide, please? So what this study showed is that there was longer real-world PFS that was seen with brigatinib compared to alectinib. The median PFS was not reached in the overall population with and without brain mets in the brigatinib arm, whereas in the alectinib arm, it was around 35 to 38 months overall with and without brain metastasis. Next slide, please. Again, there is a slight tendency to better overall survival seen with brigatinib compared to alectinib, with overall survival not being reached in the overall population as well as with and without brain metastasis in the brigatinib arm. Whereas in the alectinib, it is around 15 months with the overall survival not reached with patients with brain metastasis. Can I have the next slide? So coming to a pooled analysis of patients who were being pre-treated with other ALK-TKIs, is brigatinib really useful and helpful in this scenarios? Next slide, please. So this is the ALTA-2 trial, which used brigatinib post alectinib or ceritinib. It is an open-label, single-arm, multi-center international phase 2 study, which included locally advanced or stage 4 metastatic NSCLC, ALK positive, who had a progressive disease on either alectinib or ceritinib, and they were given brigatinib at a dose of 180 milligram once daily, and the options were to increase the dose up to 240 milligram on progressive disease, or continue 180 milligram till any loss of clinical benefit, or discontinue the therapy. And you can see from this waterfall plot that the majority of the patients had some form of response with either a stable, partial, or complete response to brigatinib post even progression of alectinib. And any grade treatment-related adverse events were less than or equal to 30%, with diarrhea being the majority of the complications, and other increased blood CPK parameters being seen in around 30% of the cases. Other like side effects like nausea and hepatotoxicity was predominantly seen in less than 20% of the cases. Next slide, please. This included patients predominantly around 80% of the patients had taken alectinib and progressed, in fact, 80%, and around 20% had progressed on crizotinib. Another pooled analysis of brigatinib after alectinib showed an objective response rate of around 30% in the intention to treat population, and the median PFS post alectinib population on brigatinib was around 9.2 months, with the median OS of stretching up to 25 months. Next slide, please. So coming to the safety and dosage, the brigatinib safety profile in ALTA-1 first-line study, as well as the comparative safety profile and dosage and administration guide. Next slide, please. So this ALTA trial showed a manageable side effect profile for brigatinib, with grade 3-4 adverse events being seen in around just greater than or equal to 2% of the population, with them 14% being due to hypertension, 5% being pneumonia, and 3% being anemia. Lower rates of psychiatric or metabolic toxicity, unlike lorlatinib. Long-term tolerability was pretty good. 42% patients continuing brigatinib for greater than 2 years, with a median follow-up of around 14 months. The discontinuation rates of brigatinib were comparable between the brigatinib arm and the crizotinib arm, and hypertension was manageable, with only 2% of the population needing dose reduction and with no population needing dose discontinuation. There was no weight gain or just minimal psychiatric impact, and only 3% of the patients in the brigatinib arm had early onset pulmonary events, that is within 14 days of treatment initiation, because of which we generally advocate a lower dose of brigatinib in the first 7 days. And all 4 patients discontinued this brigatinib when pneumonitis was seen. And of 65 patients who crossed over from crizotinib to brigatinib, only 2% experienced early onset pulmonary events. Next slide, please. So when we compare brigatinib with lorlatinib when it comes to cardiovascular risk factors, lorlatinib was associated with 3x increased risk of cardiovascular diseases such as stroke, that is nearly 5-fold, heart failure, that is, and almost tripled. And brigatinib had a very significantly lower CTVS risk. And the risk was cumulative. It increased over time with lorlatinib, whereas with alectinib and brigatinib, it kind of plateaued. Can I have the next slide, please? So the recommended dosage is around 90 milligram once daily for the first 7 days. Then the dose is increased to 180 milligram once daily, and it has to be administered until progression or unacceptable toxicity. We have to inform patients to not crush or chew the tablets. It has to be swallowed whole, not to take any grapefruit or grapefruit juice along with alembic. And if the dose is missed, we can always give it the next day. It majorly decreases the pill burden. It is a once a day dosing of 180 milligram compared to crizotinib, which is twice a day, that is 750 capsules per day, or alectinib, which is given at a dosage of 600 milligram twice daily, and that comes as a 150 milligram capsule. So the patient has to take 4 capsules in the morning and 4 capsules in the night. Next slide, please. So when we put it all together, who are patients that really stand to benefit the most from giving brigatinib? Any patients with any risk factors for cardiovascular diseases such as dyslipidemia or cardiac event like myocardial infarction or heart failure or arrhythmias, or those patients who already have a high BMI and are diabetic and have metabolic abnormalities like hypertriglyceridemias and hypercholesterolemias, and those patients who are living alone without social support with history of depression, dementia, or anxiety, and elderly patients who already have a very high pill burden and they don't want to be overburdened with higher pill burden. These are ideal candidates for brigatinib, as brigatinib does not have all these side effects and it has a reduced pill burden. Next slide, please. So coming to a short case report of a female who was around 44 years of age. She was diagnosed to have a stage 4B non-small cell lung cancer, that is adenocarcinoma, who was ALK positive on IHC and presented with the ECOG PS of 1 with not a significant treatment history or no significant comorbidities. The patient was a negative smoker. As you can see from the CT scan as well as the brain MRI and the PET CT, there are some lesions in the lung and as well as the brain. Next slide, please. The patient was started on brigatinib with a leading up dose of around 90 milligram once daily for 1 week, increased up to 180 milligram, and it was decreased to 120 milligram due to adverse events. There is a partial response that was seen in both the lung and the brain, and the first relapse was in an oligo progression in brain, and that was treated with gamma knife surgery in 1st July 2019. And this kind of treatment was given for around 4 settings at various timelines. The first being at 2019 July, December 2019, March 2021, and June 2021. And finally, brigatinib was terminated around 5 years after the initiation. Next slide, please. After which the patient was started on lorlatinib. Next slide, please. So the patient was started on lorlatinib at a dose of 100 milligram once daily, and the dose was decreased to 75 milligram due to adverse events. The stable disease and the complete response was seen in the lung and brain respectively. Grade 2 delirium was seen as an adverse event. The total treatment duration with lorlatinib alone was around 33 months. So this kind of sequencing with brigatinib for 57 months and lorlatinib for 33 months with a cumulative almost 7.5 year survival period is kind of unprecedented in metastatic non-small cell lung cancer setting. Next slide, please. This just goes on to show that this kind of sequencing works in real life. So to summarize the talk for today, it is a well-balanced TKI, brigatinib, with the median PFS of around 24 months versus 11 months. The median PFS of 30.8 months with versus 9.2 months. So the superior intracranial efficacy was seen with brigatinib of around 24 months with versus 5.6 months with crizotinib, and it reduced the risk of progression or death by 75%. Manageable safety profile. Most common adverse events being pneumonia, pneumonitis in just 3.7% of the cases, pyrexia, dyspnea, pulmonary embolism, and asthenia. And it is dosing that fits into patients' lives with just 1 tablet per day with or without food. Next slide, please. That concludes my talk for today. Thank you.
Thank you very much, sir, Shrikant sir, for an excellent presentation. So now we arrive at one of the most engaging segments of today's program, the expert panel discussion. So it's my pleasure to introduce our moderator, Dr. Animesh Agrawal, Consultant Medical Oncologist, Apollo Hospital, Lucknow, Uttar Pradesh. Joining him as our distinguished panelist are Dr. Kumar Santosh Swain, Assistant Professor, Department of Medical Oncology, IMSM Some Hospital, Bhubaneswar, and Dr. Lakshma Reddy, Consultant Medical Oncologist, KIMS Hospital, Hyderabad, Dr. Rupjyoti Sharma, Consultant Medical and Hemato-Oncologist, MOC Cancer Care and Research Center, Mumbai, Dr. Satish Sarma, Consultant Medical Oncologist, Manipal Hospital, Ranchi. A warm welcome to all our esteemed experts. Dr. Animesh Agrawal, I now invite you to kindly moderate this engaging discussion. Over to you, sir.
Good evening, everyone. Just confirming before we begin, are my slides visible to everyone?
Yes, sir, visible.
Right. So good evening again, everybody. So this has been a long and engaging session. I have been listening to the talks, Dr. Joe, Dr. Praveen, Dr. Ruhi, Dr. Shrikant, and quite frankly, there has been a very exhaustive discussion already. And I guess some work gets easier and becomes easier, some becomes a little more complicated as we move on. Because if anybody has looked at the actual mandate that we have been provided in this panel, we have to talk about NGS, किसको करना है and कब करना है. Second, what is the first line treatment and second line treatment for oncogene addicted and oncogene non-addicted NSCLC. So essentially all of NSCLC. So I mean, that's a very, very broad mandate. And I am afraid we will not be able to do justice to it in 30 minutes. So what I will try to do is, instead of looking at the granularity of the data itself, I will try to talk about the broader principles that we mostly follow, or at least try to follow in our clinic and our maybe day-to-day practice, with some loose adherence and loose references at least to what is the data that broadly guides our practice. Okay, so this is the broad outline that we'll be following. We talk about NGS, we talk about first line management, and subsequently about second line management. So the first question I will let me just involve. So Dr. Santosh, are you here with me?
Yes, sir. Good evening, sir. Yes, I am here, sir.
Good evening. Right. So you have a patient with advanced NSCLC. Let us say that this is a candidate for systemic therapy only, and he has presented to you in your OPD. When do you ask for the NGS?
Sir, I will do it fast front only, sir. At first visit only.
Right, of course. So actually, this is actually a very, very, I mean, I would say a very straightforward question. And so that the second question that I want to ask you, therefore, is what do you do till the results come back? Right. So, आपने NGS भेजा, even the fastest stat is going to still take a week. And
Yes, sir.
typically,
Yes, sir.
the whatever panels we order do take between 2 and 3 weeks to come back. So what do you do with the patient till then?
Yes, sir. If a patient is metastatic, I plan for systemic therapy. I will go ahead with a first cycle of chemotherapy at least, sir. Don't waiting for the results, sir.
Okay. Okay. So are you tempted to add VEGF inhibition or something else?
If patient name is, sir, no, sir, I will going for, sir, pemetrexed cisplatin or pemetrexed carboplatin or pemetrexed cisplatin. VEGF, sir, plus or minus. If patient having pleural effusion, then I may think about it.
Of course, for adenocarcinomas, yes, I get what
Yes, sir.
of course. Yeah. So, but typically, I don't think we are doing that. But yeah, so question worth exploring sometimes. Yeah. So किसका कराना है? So Dr. Lakshma, who do you get an NGS for? So all patients with NSCLC, non-squamous only. Or what do you do in your routine clinical practice? I mean, we all know guidelines say कि we do it for all NSCLC, but what are you doing in your practice?
In my practice, I do for all the patients of NSCLC.
Okay.
At the diagnosis, I send for NGS. If patient is symptomatic, I give the first line treatment, start on chemotherapy and wait for
Okay.
the NGS reports. If the patient is not symptomatic, then I wait for the NGS report and then decide.
Okay, so all NSCLCs, squamous also, and no selection filter,
Yes.
young non-smoker or something of that kind, no filters, all NSCLC go for NGS.
Nothing. Because we have seen squamous also a few people. Yes, adenocarcinoma, it is more common in squamous also. We have seen few cases where we were able to detect driver mutations. So that is the reason we do it for squamous as well as non-squamous. So means like adenocarcinoma, for both we do NGS.
Fair enough. No quarrels there. No quarrels, of course. And this is the data that was briefly alluded to by Dr. Juhi in her excellent talk. So this was the data that Dr. Sharma, in collaboration with TMH, published for over 5,000 odd patients. And of course, we know that adenocarcinomas have a very high rate of driver alterations. But as we can see, even in squamous cell carcinomas, in this data set of over 5,000 patients, the existence of EGFR mutations, although these are not obviously all the common ones, even the EGFR common mutations is nearly 15%, ALK mutations is nearly 5%. So, I mean, while this number seems a bit high, but still, I mean, it is definitely it's sort of thought provoking. And so for maybe it is time for those of us who have been sometimes thinking कि so squamous में क्या करेंगे भेज के, maybe we should be sending it for all. So Dr. Rupjyoti, what your take here?
Yes, hello, hi. So absolutely, we for all the patients, irrespective of histology, either it's adeno or squamous, we send NGS for all the patients.
Okay. So I must confess that actually I was until very recently I was one of those. Maybe even until 2025, I was among those who would not ask for NGS in squamous cell carcinomas, and it's only a year back that I changed my practice. So I just wanted to get a feel of how the house behaves here. Okay. So Dr. Satish, are you here with us?
Yeah, I'm there. Yeah, please.
So questions on your screen: tissue versus liquid, khali tissue, khali liquid, both. Do you ask for hotspot panels? Do you ask for CGP?
So the hotspot panel, if the patient is a corporate or financial issues are not there, send tissue and liquid both together. If given a choice between tissue and liquid, I'll go for tissue first.
Okay.
And probably
So
CGP for all the patients.
okay, right. I know, na? Us medical oncologists, हम लोग को जितना data दे दो, we want all the data. We want CGP, we want tissue and liquid, and of course, I will not go into all of the data, but yes, there is enough data to tell us that I think we should be going for all of it because
So
where
recently,
feasible.
I had a case where this patient, doctor's mother, she underwent this USG guided liver biopsy. We processed for adenocarcinoma and then we sent this liquid NGS, solid NGS, and it came as KRAS 12D mutation positive, and there was no driver mutation, there was no immunotherapy resistant marker, but somehow we also sent this liquid NGS, and that's surprisingly so STK11 and keep positive.
Okay. Right. So that then drives your choice of immunotherapy, of course.
Yes, for affording patients, affording patients, you need all the data to have the correct choice.
So Dr. Santosh, your take here, same as Dr. Satish. Anything else? Any difference in practice?
Sir, ideally I don't go for liquid biopsy diagnosis, sir. I prefer tissue diagnosis. If patient is frail, not able to go for, then I only go for liquid biopsy. So I may agree with the what sir told. Ideally, we should go for both if feasible.
So how frequently are you actually able to do it in practice? I mean, so we say ideally, right? So how often have you been able to get this ideal at diagnosis, tissue and liquid?
No, sir. I ideally do for tissue only, not both.
Actually, even me in the last, couple of years, I think only one patient I've been able to send both solid and liquid. And I also end up preferring the tissue biopsy in the first setting, and only it's in the relapse or the recurrence setting where I typically end up asking for the liquid. But Dr. Lakshma, so what about PDL1 testing? As the trials are concerned, there is a whole gamut of stains. So SP142 and 28.8 and whatnot. But in India, we only have 22C3 and SP263. At least that's what I am aware. That's what I think. So what do you ask for as far as PDL1 testing is concerned?
So PDL1 testing, generally we ask for DACO, though we know
Okay.
that there is good correlation between both the platforms that we have.
Absolutely.
My preferred thing is DACO. I go for DACO. And sometimes I don't do PDL1 testing because irrespective of the PDL1 score, except for to prognosticate, once the NGS is negative, we are going to give immunotherapy. So sometimes I might not even get a PDL1 testing done. Sometimes PDL1 more than 50% is the only condition where you give chemo, you give only immunotherapy. Even then, I prefer starting with chemotherapy unless they have developed toxicity or the patient is too
Let me just
old.
stop you there
That is when
because
I prefer giving
let me just stop you there
immunotherapy.
because that is a
Otherwise,
question I will try to come back to later on. The whole PDL1 high expressor wala issue. But Dr. Roopjyoti, so PDL1 testing. So Dr. Lakshman gave a very interesting take. Immuno to dena hi hai. In fact, it's IO plus minus chemo rather than chemo plus minus IO. So what is your take? PDL1 testing?
No, because if we see in adenocarcinoma, almost around 40-50% will have a driver mutation in India. So, and majority of our patients are having adenocarcinoma. So we can expect that almost half of our patients are having some kind of driver mutation. So if the patient is financially no financial constraint, then definitely we can go ahead with PDL1 testing in the first setting. But I think NGS is because we can wait for the NGS report. Because if there is any driver mutation, then definitely there is no role for any IO. Because even if the
And-
PDL1 is very high in a patient who are having a driver mutation, then you will not consider IO.
Fair
And
enough.
regarding
So,
your
yeah.
second question, whether it is 2263 versus SP263, so if you see the FDA approvals, so pembrolizumab approval is basically based on 2263 only. But with our clinical experience and all the trials, so they have used various markers. And but most of the times this is convertible. Basically, these have very good correlation. So I don't think it is a very specific that we should only do 2263 or only SP263. So we can do in any ways. So
And
either is fine.
what about liquid? So do you ask for a liquid-based NGS as well during our diagnosis? I mean, we are all sending the tissue. Do you also ask for liquid?
Yes, so if no financial constraints, yes, both are complementary, so as to speak. But most of the time, because of financial issues, we are not able to send liquid. If given only one option out of these two, solid, somatic versus liquid, so definitely somatic is better. Because in liquid, sometimes it's difficult to find out the fusions. So liquid biopsies can miss out fusions in most of the times. But somatic NGS is very good for picking up the fusions. So. So
Right.
given these out of these, whether we should send somatic NGS versus liquid NGS, somatic NGS is definitely better than liquid. But sometimes the issue is because in India, the biopsy is done in some different lab, and during sectioning, the tissue is very limited, and because of some quality control issues, so it becomes sometimes somatic NGS can be falsely negative, or it can be QC failure also. So in that cases, we definitely can send liquid NGS.
Absolutely, you raised a very valid point. The lab wala issue, right? Sample collection to fixing time, then fixing time kitna अच्छे से fixing का staining time kitna diya.
Yes,
All of
yes.
those
QC
technical issues
and
also
yes,
come in here.
and the quantity also, both quality and quantity of the tissue is very important.
Quantity to fine. I always give the benefit of doubt because I mean I assume that all recent IRs are trying their best to give us the most tissue. But of course,
Yes.
tissue is an issue, the famous cliche, right?
Yes, yes.
Okay.
And most of the time, what
So-
happens that from the lab we get a call that tissue is not adequate. Only 5 to 10% tumor cells are there. Whether to go ahead with NGS or not. So in that in that query, you are in a fix what to do. Now, if you do not,
Absolutely.
because we cannot do repeat biopsy again. Most of the patients do not agree for a repeat biopsy. And in that cases, what I generally do, I ask for a somatic NGS and I counsel for the patient for a liquid biopsy also. That even if you, in case we miss in the somatic NGS, then you will be able to find hopefully in the liquid NGS.
Correct. So raising some very valid points we actually face in a day-to-day clinic, Dr. Rupjyoti there. So Dr. Sharma, Dr. Satish, this name. So वैसे तो this is the entire gamut of approved therapies for oncogene addicted tumors in NSCLCs. But quite honestly, we do not have enough time to talk about even half of them. I will be sticking to the one on the left, EGFR and ALK, and perhaps the rest will have to be discussed by some other panels in the future. But coming to EGFR mutations, so Dr. Satish, how do you decide? I mean, we have a lot of therapeutic options for EGFR mutated disease by now. So how do you decide the therapy for your patients?
Of course, the age, if you have to take few the performance status, the metastatic side, suppose if the metastatic side is the brain, then of course the osimertinib becomes a choice. Then if there are passenger mutations along with the co-mutations along with this thing, then you cannot, you have to go with PEM carbo, chemo plus osimertinib you have to go. And then you have to see the patient profile also, whether they can tolerate, and then logistics, whether cost and how the costs are. And the comorbidities also, whether the patient is diabetic, like PEM plus osimertinib. I had a very bad experience where patients generally develop AKI. So this all things are
So I
there.
think that AKI thing, a lot of people talk about that. So the AKI thing it's a feature of pemetrexed. It's a feature of to a much lesser extent of OSI, but together those do not seem to do well for AKIs. Yeah, true. So you have already briefly talked about the regimens that we are using. So Dr. Santosh, these of course are the three regimens that we today are choosing from. And I have very briefly just given us the headline numbers here. Flora 2, Mariposa, you have all three options at your disposal. Let's assume for theoretical sake, you have Lazertinib as well. So which patient are you choosing for which regimen?
Sir, of course, Mariposa is a better option if a patient have no issue and no comorbidities. Then and the deep pockets, then I will choose for Mariposa, sir. For nowadays, Flora 2, Mariposa is theoretical most of the time. But in my clinical practice, I stick to at least Flora, sir. Flora 2. Chemo plus osimertinib. It is feasible, sir, and the patients are tolerating well, sir.
Right. Okay. So you find when you say tolerating well, you find that patients are able to complete those 4 cycles. They are able to go on to maintenance pemetrexed, because even in Flora 2, there was a lot of chemo discontinuation.
Yes, sir. If patient is frail, then I will little skeptical about Flora 2. Otherwise, if patient is fit, then I choose Flora 2, and most of the patient, around 50 to 60% patients are able to maintain at least.
Okay, so yeah, 50 to 60. I think 50 to 60% sounds about a fair number. Little over half of patients are able to continue on Flora 2. But Dr. Lashma, so let me ask you this. So let's not say that the patient is frail. Okay, so the patient is not frail. Patient is fit. Patient has deep pockets, as Dr. Santosh said colloquially. So this is the patient who theoretically you can have the option of Mariposa as well. But of course, we all have the sequencing question in mind as well. So how are you selecting your patients for first-line therapy? Dr. Lakshma? Dr. Rupjyoti, perhaps you can take that?
Yes. So all these options are valid options. So in currently practicing, in current practice, we don't, because we don't have Lazertinib as of now. So Mariposa Amivantanab was given along with Lazertinib. So for the time being, we are continuing with FLORA2 only. But in Mariposa, if you see the final OS, there is around 1 year of difference in the final OS between the FLORA2 and Mariposa. But until we are very much, so there are two things. One is the financial issue, and second thing is the very much toxicity with the amivantamab. So unless we are very much well conversed with managing the toxicity, so till then we will have FLORA2 as the first line of treatment.
So then let me play devil's advocate here. When you talk about OS, so the 3-year OS on Mariposa is on Ami laser is around 60%, right? So it is anticipated that the median will be in the same vicinity, same ballpark as FLORA2. Is it? No, it's a very reasonable assumption to make. 3-year OS 60%, 4-year OS 50%, and in FLORA2 the median survival is around 4 years. So I mean, if the survival seems to be similar, so and amivantamab, you also get to save amivantamab for the second line. From your sense conversation, I would say that you were suggesting that if you had lazertinib, you would prefer to go Mariposa. Is that correct?
So there are two things. One thing is the toxicity, because we will have to manage the toxicity also. Unless we are able to manage toxicity, then there is so we should not have grade 5 toxicities and treatment discontinuation because of the toxicity. So those things also we have to keep in mind. But because we don't have lazertinib as of now yet, and we do not know whether amivantamab can be, how the toxicity will be, because amivantamab single agent is very difficult to give, and unless we have lazertinib, till then we have to give either with osimertinib. So that is the option. So osimertinib itself is a toxic drug to give. It's not a very easy drug. So it will be very difficult to combine with amivantamab. So till then we have to, I think, be satisfied with FLORA2. But yes, Mariposa data looks definitely good, and it definitely has OS benefit compared to FLORA2. At least, and we expect that in the longer follow-up, in the final OS analysis, so there will be a gap of around 1 year. So if we give Mariposa, then in the final, we expect that the patients will be able to live 1 year more longer. So that is the thought process right now. But amivantamab is definitely a difficult drug to give. Even single as an amivantamab without chemotherapy or without any targeted therapy.
While I would love to get down into the weeds of the data here, post-progression therapy and all, but I think time would start becoming a serious constraint. So I mean, I think we will leave it at that, definitely. But all three are valid options. So I mean, I think the panelists agree here that FLORA, so osimertinib remains a valid choice for a patient where we are skittish about using chemo, and where we are not, FLORA2 makes the most sense today. Both chemo, Pemicis and Pemicarbo, along with osimertinib drugs that we are commonly using in our practice, have been using for a while and are comfortable combining as well. Mariposa, once lazertinib becomes available, of course, becomes a very attractive option to use. I suppose time tells us how the data can go on in the long run. So, Dr. Satish, what about the uncommon mutations? Afatinib or osimertinib? I mean, NCCN allows us to use both afatinib and osimertinib. What are you using in your practice? We do not have phase 3 data with osimertinib for uncommon mutations. Dr. Satish? It appears he might be somewhat occupied. So, Dr. Santosh, what do you think here?
Sir, I generally use the afatinib, sir. In the uncommon mutations, I am comfortable with the afatinib. And patients are responding also, sir.
Absolutely. I mean, I've also been using afatinib for a very long time for these patients now. And yes, they respond well. And actually, they do respond for a very long time. And
Yes,
I mean, even the data that we have seems to suggest that afatinib gives us a better ORR and PFS. But the NCCN allows us to use both options. And now we also have data from amivantamab, from the Chrysalis data, and some other phase 1, phase 2 data as well. So, I mean, we have options there as well. But yeah, at least I'm using afatinib in my practice. What about you, Dr. Rupjyoti? Or Dr. Lakshma, are you here with us?
Yeah, I'm here. Generally we use afatinib only. I prefer using afatinib than osimertinib when there is these atypical mutations are there.
Right. Yeah, I think that's a bit of a consensus there. Afatinib only, osimertinib maybe for certain specific situations or use cases. Yeah, and amivantamab तो अभी हम लोग common में use करने से हिचकिचा रहे, तो uncommon में तो I think we are all waiting. But upon progression, Dr. Lakshma, so now what do you do? We did not do the liquid biopsy. I believe that we were talking a little earlier, right? So now the patient has progressed on first-line therapy. Now do you do the liquid and tissue, both? How do you do now?
No, means like it depends. Means like preferably, if possible, if there is progression, I prefer doing liquid biopsy at progression.
Okay.
Okay, until unless I'm suspecting some small cell transformation out there. That also
Okay.
sometimes we can detect through the mutations, but rarely we go for tissue biopsy. Otherwise, I prefer doing liquid biopsy at progression.
Okay. But as Dr. Roopjyoti, I think, was pointing out that liquid ecto will sometimes not pick up fusions, right? And sometimes it is also not very good at liquid. Sometimes will not pick up the fusions, and sometimes it can end up missing. क्या कहते हैं? I have at least on a couple of occasions I've found that liquid biopsies did not pick up MET amplifications that the tissue biopsy picked up, and I was very surprised by that. But that's what something that's I mean that's an example of something that can happen to us, right? So we say कि नए lesion का biopsy करो.
Ideal thing to be done maybe would be doing a biopsy from the site of progression, but many times we might not be able to
Not
do the
doable.
biopsy.
Absolutely.
So that is the reason we send for a liquid biopsy. Okay.
So just a final question. I'm sorry to be probing you like this, but final show of hand. When the new lesion, what is your preference? New lesion ka biopsy or liquid? Your preference, if you have to choose.
So it depends on the center that you're working with. Like when we were working in Tata Memorial, yes, at this we used to take a biopsy from the site of progression. But later on, once we are into this corporate where you have to manage the patient as well to make them comfortable, that is when you choose doing give them both the options. Sometimes you end up doing only liquid biopsy.
Fair call, absolutely. Again, coming back to how we actually work in our clinics.
Yes.
So, Dr. Roopjyoti, so how frequently do you advise, say, a tissue biopsy, say a liquid biopsy, and how frequently do you advise both? And we are talking about progressive disease.
Okay, so important thing is regarding this new metastatic lesions. So, are these easily accessible for biopsy? That is the most important thing. Suppose there is some lesions in the brain, we cannot go for a brain biopsy. And secondly, if there are only few lesions in the liver, in the bone, so there is no point in doing a bone biopsy. So in those cases, liquid biopsy is fair enough. But in other cases where the new metastatic lesion is easily accessible and can be done without much complication, then definitely tissue biopsy will give us two answers. One answer is whether there is any transformation, and secondly, if there is any new mutation. So tissue biopsy is definitely preferable if easily accessible without complications.
So out of 10 patients, how many patients, I mean, practically speaking, in your OPD, out of 10 patients, how many get a tissue biopsy, how many get liquid?
Around 70-80% will get a repeat biopsy done. Yes.
Okay. So around 1/3 go for a liquid, so 2/3, 1/3 split, let's say.
Yes.
Okay. Yes, okay. Sounds fair enough. So, well, fine. We did the repeat biopsy. There are no escape mutations, either on target, off target, right? So let us. So Dr. Satish, are you there? So Dr. Santosh, maybe you can take this one by one. Let's. We'll just come to. So after a patient has received osimertinib alone, Dr. Santosh, what does he get afterwards?
Sir, if a patient is on osimertinib, we are having the option of amivantanab. In the first line, if patient receive the only osimertinib progression,
We are assuming that the patient is financially capable. We are assuming that the patient is medically fit.
Yes, sir. Then if patient medically fit and financially eligible and drug is available, then I will prefer amivantanab as a second choice after osimertinib, sir. After going through the liquid biopsy and any amplification or mutations are excluded, then I will go for this, sir.
So Dr. Lakshma, slightly tougher for you. Patient has now received pemicarbo plus pemicarbo plus osi. Now what do you use? Mariposa 2 actually had amivantamab plus chemo. What do you do now?
So I think amivantamab as a single agent has also been approved. So if you have already used pemetrexed with carboplatin, then you can use amivantamab as a single agent post progression on osimertinib. So even that is an option. Combining it with taxanes would be toxic, I think. Combining taxanes with amivantamab would be more toxic for the patients to be tolerate. So you can try amivantamab as a single agent. That would be a good plan. Before doing that, yes, once the patient has progressed on this, we need to find out what is the resistance mechanism. That is it the small cell transformation that has happened? Oh, that also to be made sure of. If it is there, small cell transformation, you need to consider chemotherapy. Yeah.
Point taken. Absolutely. And so, Dr. Roopjyoti, the toughest question for you for last. Mariposa lag gaya patient ko, now what?
So TROP2 ADCs are coming. So I hope if the patient has got Mariposa in the first line, finances would not be an any issue. So definitely I will counsel for TROP2 ADCs.
Okay. So no chemotherapy, straight to ADCs?
Yes, it's approved. If feasible, yes.
Fair enough. A very short and sweet answer. I happen to agree. I do not have much disagreement there. But when we have the over 2 decades old data, I mean, somebody, I don't remember who, somebody said ki docetaxel is like a cockroach. Jaane ka naam nahi leta in second line NSCLC. But finally, with the ADCs, with the ADC era, I think we are getting there. And what about the uncommon
drug to give basically?
Absolutely. And वो भी second line NSCLC तो nightmare. What about patients with uncommon mutations, right? These have mostly received afatinib. The subsequent drugs aren't very effective, but I mean they're hanging around. So what do you use?
So chemotherapy basically, yes. Pemetrexed based chemotherapy, carbo.
Chemotherapy. But I mean, what about we do have data for both osimertinib and amivantamab?
Because in I think Mariposa they have a phase 2 data in the first line itself. I do not remember any in the second line.
Okay.
If that has if the
Fair
trial
enough.
uncommon mutations, yes.
Fair enough. So, I mean, briefly speaking, we also have some data for the ABCP, right? And who was talking about it? I think Dr. Joe briefly mentioned it, right? So, the Atlas trial actually enrolled patients post EGFR and ALK TKIs. It's another matter that around 90% patients were post EGFR TKI only. And for those patients, the overall response rate was around 70%. So not just the ADCs, actually ABCP is also an option for us. I mean, we have a phase 3 trial in this setting for us. So ABCP also becomes an option. In fact, that is that is what I tend to employ in my practice for a patient who has poor program. I mean, if I'm not using amivantamab. So yeah, that is also an option here. Although the OS benefit isn't there, definitely PFS improvement is there. So yes, that's another option. Yeah. Coming to ALK, so Dr. Santosh, we had a brief session earlier. 7-year PFS 55% versus 3%, and I mean the numbers are simply not mature for OS. For patients with brain metastasis, 7-year PFS of 53%. I mean these are stupid numbers. So my question is simple. I mean, is there a patient for whom you will not use lorlatinib? I mean, there are of course some patients for whom lorlatinib is not suitable. What I'm asking is, who is that patient?
Sir, lorlatinib having some specific side effects like weight gain and some neuropsychiatric problems. I have seen patients those having the suicidal tendencies. So in that and those patients having dyslipidemia, common side effect. Patient having already hyperdyslipidemia. So in that cases, I am little bit skeptical using the lorlatinib, although patient is fit for that, but due to contraindication for the drug itself, I will be little skeptical using the lorlatinib, sir.
Right, and possibly regard maybe certain specific mutational profiles where we know that lorlatinib doesn't work, but that is not a very common scenario. But fine, yeah, that is also there. But Dr. Lakshma, after ALK TKI, what second line we have, I mean, given the kind of responses we get, it is going to take a while before we exhaust ALK TKIs, but Manlo patient has exhausted them. So what next?
Mostly it will be chemotherapy.
Okay.
Yeah.
Okay.
Some of the other chemotherapy, we try some chemotherapy is the option.
Okay. What about immunotherapy here?
VEGF inhibitors were also not found. Immunotherapy was not found to be beneficial even in second line post exhausting the target agents in ALK mutations. So I don't think there is much benefit by using immunotherapy in second line in such scenarios. So chemotherapy would be the better option. Sometimes we need to see the mutation, means like what mutation it is. Sometimes you can use other ALK TKs post progression one ALK TK. Sometimes it has happened like where progression on alectinib, there are some few mutations where they are sensitive for crizotinib. So we also need to rule out which mutation it is and then decide about the second line of treatment. So mostly it will be chemotherapy once there is no other drug that is eligible to give.
Right, absolutely agreed. So agreed on all counts. And in fact, in the Atlas trial that I talked about, while the benefit was definitely there for EGFR, the benefit was not there for ALK. So yeah, agreed. Chemotherapy, IO, so far we simply do not have encouraging data, and I'm not sure who about this. There's this trial briefly. We do have at least some upcoming TKIs beyond the ones that are already available. ALCOV1 data was updated in ASCO this year as well. So some data coming up, but yeah, beyond the ALK TKIs, it's only chemo so far. So yeah, that's that. I think that we'll have to stop that for as far as oncogene addicted tumors are concerned. What about, as for the non-oncogene addicted tumors, when we are talking about first line therapy, remember for the drugs that are available for KRAS, HER2, and NRG1 are not approved in the first line. We are all talking about second line systemic therapy here. So even for patients with these mutations, first line treatment would entail chemo IO, or at least which particular chemo IO is the bigger question for us in this particular scenario. So Dr. Roopjyoti,
Sorry to interrupt.
your take.
So 2 minutes left for the session.
Right. So, okay. So Dr. Roopjyoti, let us combine. We have, first of all, we have all the OGs, so to speak. We have Keytruda, we have Opdiita, we have Imfinzi, and of course, we now also have the Chinese drugs, right? So serplulimab, tislelizumab, and we even had the Harmony 6 data at ASCO this year. What is your choice? How do which regimen are you choosing?
Okay, so we have very good experience with Keynote 407 in PD-L1 positive patients in squamous cell carcinoma. But ESTRAM data and serplulimab data, and in clinical practice, it does very good responses. So definitely these two will be first choice. In PD-L1 negative SCC, SECMET 9LA has very good data, but definitely combining two IOs, dual IO is difficult in clinical practice to give to everyone. Financial issues apart, the toxicity also matters. So as of now, both Keynote 407 and ESTRAM 004 is a good options for us, for our patients.
Okay, I couldn't have summarized that better. Quite a lovely summary, frankly. Thank you for that. Then coming back to you, Dr. Santosh, for adenocarcinomas. Dr. Santosh?
Yes, sir. Yes, sir. Sir, I generally preferred Pembro plus Pemcarbo, sir. Keynote 189, sir. I'm comfortable with that regimen, sir.
Okay, Keynote 189. So what about the Chinese IO drugs? I mean, all patients are not going to be affording Keytruda.
Sir, now this is in the new drug in the board, sir. Every discussion in going there. So if opportunity came, then I will try for serplulimab plus Pemcarbo, sir.
Have you used it in your clinic so far?
No, sir. I have no experience with that. I am experienced with Pembro plus Pemcarbo, sir. I'm preferring this regimen and I'm more acquainted with this regimen, sir.
Okay. But as far as high PD-L1 expressors and immunotherapy monotherapy is concerned, so Dr. Roopjyoti, are you using immunotherapy monotherapy? I mean, recently I came across this meta-analysis published in JAMA, right? So for 24 trials or around 5,500 patients, both PFS and OS are superior when chemo IO is compared to IO monotherapy, and we are talking about high PD-L1 expressing tumors more than 50%. So as per this meta-analysis, all patients where possible should be receiving chemo IO. But what are you doing in your practice?
Okay, there is one important clinical aspect that we also need to consider apart from the data. So if a patient has extensive disease, a patient is very symptomatic, and if you give single agent IO definitely takes some time to work. It's not kind of
Absolutely.
the chemo works within few days or few weeks, but unfortunately with IO it takes some time to get the response. And till that time, the patient may deteriorate. So it has happened in our clinical practice. We have given single agent IO in PD-L1 more than 50%, but unfortunately, we could not manage the clinical progression. So that is the one important thing that we should also consider. And if we see the graph of that trial where pembrolizumab alone versus pembro plus chemo in more than 50% PD-L1, that in the trial also the curves were very though in the single agent IO, that curves are dropping in the initial 3 months. So that is the most important thing. So only in the patients who have very limited disease, asymptomatic, then in those cases we can probably consider single agent IO. Otherwise, most of our patients will be in advanced disease symptomatic. So in my clinical practice, I will not consider single agent IO. I will always combine with chemotherapy plus.
So if you have a patient who is fit but has limited who has very limited disease
Only
burden,
very small lesion, 2 pleural nodules, a single lung mass 2 to 3 centimeter, asymptomatic, only because of some cups the patient was diagnosed. In that case, we can consider. But otherwise, patient who is having pleural effusion, who is having brain met, so no. In those patients, definitely I will like to have a very good response as early as possible to get symptomatic relief and no clinical progression.
And even practically in our OPDs, I mean, अगर patient को response नहीं मिलता, if the patient does not have a response, patient does not have symptom relief, then what are we actually doing treating the patient at all?
Yes,
So
exactly.
yeah, that is, yeah. I mean, like I said at the beginning, we tried to talk about all of NSCLC management in 30 minutes, which was never going to happen. And I am going to be skipping this part of the presentation completely because it's already quite late and everybody has their family to go back to. So thank you for your time, gentlemen. And it's been a nice discussion. We have a bewildering array of choices for management of our patients with NSCLC. And I guess that's good for our patients, not so good for us. But definitely there is no one size fits all. Every day, every conference, there is more and more data. Maybe with time, we get more clarity or less clarity. But definitely, it's good to have discussions, talking to such people, talking to such a diverse array of oncologists. Thank you for your time.
Thank you. Very nice moderation. Thank you.
Thank you, sir.
Thank you, sir. Thank you very much to our moderator and distinguished panelists for such an insightful and practical discussion. So, as we come to the close of today's program, it's my privilege to propose the vote of thanks on behalf of IAIO. I extend my heartfelt gratitude to our respected program director, Dr. Suresh Babu, for his leadership and guidance, and all our esteemed speaker for their excellent scientific presentation, and our moderator panelist for their enriching discussion, every participants for your active participation and continuous support. With this, we conclude today's session. Thank you once again for joining us. We wish you good health, continued learning, and a wonderful evening ahead. Stay safe, stay healthy. Good night, everyone.
Good night.